All right. I want to welcome you all again and thank you for attending this webinar. My name is Chloe Daniels and I'm with the Chest Foundation, and we've got a great lineup today to talk about patient and clinician engagement in treating pulmonary fibrosis. And because we have such a packed agenda, we'll get started right away with with giving everybody a quick introduction of our panelists. And so we'll kick it off with Carolyn giving a quick introduction.
Hi, my name is Carolyn Adams-Duda. I was diagnosed with IPF in February of 2015 at the age of 51. I currently work full-time. I'm married. I have 3 children in their 20s. I stay very active, and I like to run.
Awesome. Dr. Cosgrove?
Yes, hi, my name is Gregory Cosgrove. I'm the Chief Medical Officer for the Pulmonary Fibrosis Foundation and a practicing pulmonologist seeing patients for the past 19 years here in Denver, Colorado at National Jewish. So I interact with patients in several different arenas, both as a clinician, but also advocating them at the national level as well.
Great. And Dr. Lederer?
Yeah, hi Chloe and hi everyone. Really excited to be here. My name is Dave Lederer. I'm a pulmonologist. I see pulmonary fibrosis patients in Manhattan, New York at New York Presbyterian Columbia. I also actively engage in research in pulmonary fibrosis and very passionate about educating and advocating for patients with PF. And I serve as a senior medical advisor for the Pulmonary Fibrosis Foundation.
Great. Michele?
Hi, I'm Michele Peters. I'm Executive Director of Team Jeffrey for PF. It's a 501c3 corporation. I was a caregiver for my husband Jeffrey during his 5-year battle with IPF. I'm still very active in the PF community. Team Jeffrey for PF holds several fundraisers each year. I facilitate a PF support group in Elmhurst, Illinois, and I'm also a former PFF ambassador. Our organization works to help patients and their families, to raise awareness, and to help support research.
Awesome. Thank you. And last but not least, Patti.
Thank you, Chloe and Angela, and I'm so thrilled to be with everybody on the call. I actually got into the pulmonary fibrosis space because my mother had the disease and ultimately passed of it. From that, I went on to head the Pulmonary Fibrosis Foundation for several years and had the great pleasure of working with so many in the community. Over the course of this last year, I switched positions and I'm heading up a high school for all girls, but we have quite a connection in the community where I sit on a board for Resurrection University, which is Nursing and Allied Health. I work with President St. Mary and Elizabeth Hospital on their community board. Still very much an advocate in the space and believe in a lot of intersections between education and public health. So thank you so much for having me.
Wonderful. And we are so excited to get started. Thank you all for your introductions. We are going to start with our first question. So what does engagement mean to you? And we'll start with Carolyn.
Oh, well, thank you. Engagement means to me a connection with my clinician, my caregivers. It just means a personal connection to me. It's somebody who tries to understand me and not just my disease. It's an understanding of what I need and what might work for me. Treat me, not treating, treat the disease, but treat me as a person, not just a disease within a person. When I was first diagnosed, I was told that I would no longer be able to run, that my body wouldn't allow it, and that the IPF disease would not allow me, and that I needed to find something else to do. This obviously, it devastated me. At the time, running was my stress relief. It gave me joy. And here I was told right off the bat, you can't do this anymore. at that time, I was extremely frustrated. Of course, at that time, I did the opposite of what I was told by the clinical staff that I was seeing, and I ran. And instead of doing what they told me to not do anymore, I decided, why not? Let's try the opposite. And so I ran. And since I've been in my journey, I've met and had other experiences with other clinicians and other people and organizations. The CHEST program here, the Pulmonary Fibrosis Foundation, and the people that I met and the people that I've dealt with, they treated me different, and they encouraged me, and they treated me not a person with a disease. They treated me as a person, and what was going to be best for me. And that changed a lot of my attitude when that happened. For me, the engagement, it's about the person. It's about my quality of life. It's about being positive. If I want to run, what is it that we, the people that I'm surrounding myself can do to make that easier for me? Can I do breathing exercises? For me, engagement is having somebody understanding me as a person, what is going to make my quality of life better, and what is it that they can do to assist me with that quality of life. And so I don't want someone to treat me as a patient. I want someone to treat me as a person. It's not just about the disease for me. It's about me. And so engagement for me means that the clinicians, the support groups, they treat me as that person and engage in me instead of, yes, of course, the disease, but me primarily, first and foremost.
Perfect. Thank you so much, Carolyn. Michele, how would you define engagement, especially as someone who's not only an advocate for pulmonary fibrosis, but also was a caregiver to Jeffrey?
Well, I really want to thank Carolyn. I love that, to treat you as a person. I think that is so important. For me, it kind of means a collaboration, a team approach to treating the patient. The patient's actively involved in their care and treatment, and the physician listens to the patient, understands their goals, what they want from their quality of life. Even sometimes when maybe what the patient wants isn't, and disagrees with the physician, but it isn't necessarily harmful. I see that the patient would interact with and listen to the doctor as well. And for IPF and PF patients, I think it is not unusual at all to visit several physicians before you find that one that you feel comfortable with, that you kind of click with, and you get that level of engagement with that physician that you're looking for, and that will ultimately help you on your journey with this disease.
Perfect. Dr. Lederer, would love to hear your thoughts as well.
Sure. So first, I want to say I think that Carolyn and Michele's comments very much reflect my own perspective on engagement. I want to say a few things. So from the physician perspective, for me, it's thinking about the patient and their family as people, and which sounds like something physicians ought to do routinely or do routinely. And I'm not sure that's always the case. Even myself, when I go to my primary care doctor, I certainly feel like a patient. I don't know if I'm always treated as a person or recognized in that way. And so engaging with people, meaning that whether it's physician or someone else, engaging with the patient and the family beyond the medical information. So beyond, here's this medication, or here's, the details of how you use oxygen. For me, engagement really involves, a lot of communication, and a lot of that's done in person and some of it's done on the phone. But in the clinical encounter, communicating about not just here's, you should use 2 liters of oxygen. It's much more than that. It's, well, what are the barriers for you to use oxygen? And, how do we make this work in your life? Is it even appropriate for you? Even if it's medically appropriate, is this something that you don't value? What are your preferences and values about your care and about the treatment recommendations we can make? Now, I will say, as a physician, I definitely have strong opinions about what I think my patients should do, and I try to communicate to them those very strong opinions about whether it's medication, oxygen, rehab, transplant, or something else. But I also try to hear their side of view, their point of view, and see how we can mix our preferences and values to come up with a plan that we think is best for that individual patient and for the family. Most of the patients I see don't come alone. They come with a spouse, a sibling, an adult child, a parent sometimes. So it's certainly not just the patient. And I know I'm talking for a little while, but I want to make kind of 2 or 3 more brief comments. One is, I do think as the physician that this is a challenging thing. And I know it's challenging for patients too, but as a physician with time constraints in the office, and with just for me, going and seeing a lot of patients throughout the day, it is much easier for a physician to just focus on the medical stuff and barrel through the day of, say, outpatient care. And I try my best, and I don't know that I'm always successful, but I try my best to, again, kind of step away from that mode or that.
Oh, I think we might have lost Dr.
I think physicians.
There we go.
I'm sorry. I think physicians, often fail, but often succeed at doing this. And I think my patients, at least in my experience, do a much better job of trying to engage with me than perhaps I do with them. So I think I'm constantly learning from patients. 2 other very brief things. One is, it's not just physicians. There's a whole team. There are nurses, social workers, physical therapists, respiratory therapists, and others that are part of the team. We don't all engage with the patient at the same time, right, often, but it is a team approach. And then just the very last thing briefly is research, where patient and caregiver engagement and even community engagement, so not just a researcher studying pulmonary fibrosis in a patient, but sometimes engaging a community is a really important area that's really not discussed enough, but well, it's just very important. I guess I'll turn it back over to you, Chloe. Thanks for letting me speak about that.
Absolutely. Next up, Dr. Cosgrove, and then Patti. We'd love to hear both of your thoughts.
Sure. Wow, I start out with simply because I think everything that's been said is really heartening to hear the perspectives, and I share, I think, all of them from the patient perspective. I think engagement to me is a relationship, and there's a physician to patient relationship, but I like the comment that it's really a personal relationship that I think we succeed in developing and understand. I've heard goals of treatment because there can be dramatically different from one patient or a family to another. So really understanding that, and that really guides the care of patients in many different ways if you understand the goals. And that's a priority when, as a clinician, I see patients to try to understand what they look forward in the day. And I really like the concept of not setting restrictions without a logical approach. Since they're telling someone they can't run when that's their primary source of or one of enjoyment and stress relief. I think sometimes we do that unintentionally as physicians without a lot of strong evidence, and so I think that's an important aspect that I take to heart, is trying to understand if I'm going to set restrictions. There has to be a really good reason for it, and sometimes that doesn't occur, and that I think builds out of a relationship, understanding what's important to a person when you're seeing them. And I think, as Carolyn indicated, it's a person, not a disease. They're not a diagnosis. And And that changes the focus, I think, as Davis mentioned and Michele, because then we care for or assist in the care of those individuals, and hopefully bring in other providers that can help understand and help break down those barriers, such as oxygen or pulmonary rehab or other things, independent, and then understand the goals of medical therapy in terms of pharmacologic therapy for certain diseases. And the other thing that one of my colleagues, Jeff Swigris, has mentioned multiple times is that we really want to inform patients about the information we have about the diseases honestly, but also we don't need to destroy hope. And I mention that simply because in a set of diseases like that comprise pulmonary fibrosis, a clear understanding as to what is going to happen to the individual patient, despite a lot of really good epidemiologic studies, it isn't possible most of the time. So we really have to provide that information in a context so people understand the potentials of what could happen for their disease, but also make sure that they're as healthy as possible as a person, and prepare them to be the healthiest that they can be, and not expect that their disease might proceed down one path. Because as physicians, I know David and myself get frustrated in the inability to predict the future, and sometimes that is excellent for patients because they're stable and they continue to be active and vital, as we heard running with Carolyn. Unfortunately, in other patients, they may have an alternative course where their disease can be more rapid. So understanding that, but also continuing to care for them in all the aspects of their life, and not just for their pulmonary fibrosis. That, to me, I think is a component of, as a physician, of engagement. And I take that to the next level and try to think of ways that at the Pulmonary Fibrosis Foundation that maybe we can do that on a larger scale outside of the exam room, so that maybe as communities where patients have the opportunity, and Michele and Carolyn can comment on this as well, where they can interact. And I think they get so much information from one another, share different experiences, but also have the personal interaction that really doesn't happen in the physician's office room and can't, but is so vital with the support groups, and interacting with other individuals who've been affected, whether they're patients themselves or, as Michele can comment, that the difficulty as a care provider that patients need to understand, but I think other care providers, and I know Patti has extensive experience with the community as well as personally with that importance of the support for both those individuals in the journey, which is the last comment I'll make that Dave made. It really is a journey, and the only reason, or the only way you can engage one another is if you see each other fairly regularly. That with a complex disease, there's so many issues that have to be discussed, and the only way to discuss them is see each other on a regular basis and address the multiple arenas, depression that can occur, as well as the lung abnormalities, as well as oxygen support. So it's a dynamic, ongoing journey and relationship. And Patti, I'll maybe turn it over to you, or back to Chloe, sorry.
Yep.
Well, I can jump in, Craig. We're so used to going back and forth. So, you know, Chloe, I thought it was interesting that you and Chess decided to have this webinar with this fantastic panel on Rare Disease Day. And I think one of the things that I've seen is, you know, whether IPF or PF or whatnot is rare or not, and we will get into that. And I think the registry that Dave and Greg and Dr. Flaherty and Dr. Collard have put together, you know, we'll find out some fascinating facts and input. But I guess it comes back to the fact that if this disease is in your life, what are you going to do about it? And then how are you going to play that out? You can call it rare. You don't have to call it rare. It's just something now that we have to deal with. And I think what I've seen personally as well as professionally is that you have to be able to trust the accuracy of the information. You have to make sure that it's clearly communicated and that you can have an exchange about how to handle that. It's very lonely. And do you have support? And what does that look like? Whether it's your team that you're a part of on your journey, as Greg and Davis said, whether it's kind of developing that voice for somebody else, like Michele or Carolyn's own voice. You know, I think it's identifying what does that look like for you in your role, and how do you make something more collaborative? How do you make something empowering? And how do you have hope that together you will not feel lonely, that we can push the needle forward, and that together we will define what is that new normal when or if this disease ever comes into your life.
Perfect. All right, so on to our next question. How do you approach engagement at the first encounter? And with this one, let's start with Michele.
Thanks, Chloe. I can tell you that there was absolutely no engagement at our first encounter with a pulmonologist. As with most patients with IPF, it was something we had never heard of. So once we got to the referral of the pulmonologist's office and, you know, kind of were given the diagnosis, we didn't even know what questions to ask because we had never heard of it. We had no clue. We hadn't really done any research or anything like that. I can tell you, though, that I still distinctly remember that day, and I probably always will because it was truly a defining moment in our lives. I tend to look at things now, oh, that was before diagnosis. Oh, that happened after diagnosis. So it makes that big of an impact in a family's life. So after not getting any information and not knowing any questions to ask, we quickly learned that we kind of had to prepare for the appointments. And we, again, searched the internet as everybody does. So that gave us at least some knowledge of what we were facing. So we just made sure that we were prepared every time we went for an appointment and tried to use the limited time that we did have with the doctor to the best of our ability, get as much questions answered as we could.
Dr. Cosgrove or Dr. Lederer, how are you approaching it in your daily practice?
I guess I could jump in. I'll say I do think that the first visit with a new patient is extremely jam-packed, and I think Michele kind of alluded to that. And it is very intense, particularly, of course, for the patient and the family. But honestly, it's also intense for me because I'm a human being and I'm communicating about a serious disease to a patient. So I am trying to, as best I can, put myself in the patient's shoes. I'm not sure I can really do that, but I try to do that and experience it in that way. It is a packed visit, as I said. There's a long period of me listening to what's going on. There are some directed questions I ask, of course, examine a patient. And then I usually spend probably 30 plus minutes educating patient and their family, sometimes less, sometimes more, about this disease. And of course, at the first visit, there's often a lot of uncertainty about exactly what's going on. So that makes it even more confusing, I think, for the patient, especially for a family of diseases that's already very confusing. So I do, through that educational process, do my best to engage with the patient and their family member if present, to elicit kind of their level of knowledge that they already have. What are they comfortable hearing now? What might they not want to talk about now but want to talk about at a future visit? I will say that the PFF has really fantastic educational materials that I actually use during the visit. I use the PF informational brochure, which is available on the PFF website, pulmonaryfibrosis.org, or through the Patient Communication Center at PFF, which is pcc@pulmonaryfibrosis.org. So you can get it in the mail. It is a really fantastic informational brochure designed for patients. And I actually go through two of the pictures in there and one of the tables of information in there on pretty much every first visit. And it really helps using pictures, even though it sounds simplistic, using pictures and talking through the disease is really a great way, not only to educate patients, but to get patients to open up and ask questions and engage in that way.
And Chloe, this is Greg. I might add that that's great, Dave. And I think the underlying tone that Dave said is, and Michele alluded to it, it takes time. That number one, for a patient and a family to begin to trust, as Patti mentioned, about the information that they're being provided, for the physician to explain it, and to be honest, for the patient and family to absorb it. As Dave mentioned, the amount of information that can be conveyed in a complex disease, there's somewhat of a finite period. And so I think as physicians, we really have to take stock in communicating important points, but not overwhelming patients. And that takes time. And I think the corollary to that is we actually have to listen to patients, and I think Dave alluded to this, and understand maybe if they're comprehending what we're saying, if we're communicating at the right level. Some patients are very, very sophisticated, and they come in already knowing about all 100 and plus different interstitial lung diseases, and they understand the ramifications of an accurate diagnosis, as Michele alluded to. I think that cannot be understated, that a lot of what we discuss with patients is really contingent upon what diagnosis they have, whether it's IPF or chronic hypersensitivity or rheumatoid arthritis. That really has to be the primary goal of maybe the first few visits, to have an accurate diagnosis, because it can dramatically change the discussion, and the ramifications of that are quite clear. So it's builds that relationship, making sure that we're just not checking boxes for a diagnosis, but we're coming up with the best diagnosis at that time. And I think that engenders two things. Number one, that you really care about the patient, about making the best diagnosis for him. And I don't use the word right diagnosis, it's the best diagnosis, because some things change over time. And so it underscores the importance of a serial evaluation and continually reassessing to see how the disease is affecting patients and how patients are functionally moving forward in their life. So it's a pretty dynamic process, but when you do engage an individual and their family, it really is quite meaningful. And then you do begin to have the opportunity to talk about the issues that are a little bit more difficult, in terms of the impact on one's quality of life, the impact on the spouse's quality of life. And those things sometimes are lost in an otherwise complex visit. But when that trust, as Patti alluded to, is developed over time, those conversations become much easier. And whether they're over the phone in between formal visits or through other forms of communication that I think is changing medicine, whether they be social media or even email. Sometimes it's a quick question that you just can't get in. That really can make a big difference. And Dave has a wonderful blog that he goes through a lot of these issues that patients can read about, and there are other fora out there that I think provide new mechanisms to share ideas and feelings. And so I just wanted to at least add those comments to really Dave's wonderful discussion.
Thank you. And Carolyn, we of course would like to get your perspective too on how you approached the encounter and engagement at your first encounter, and maybe what, if possible, you would have done differently, knowing what you know now.
I'm sorry, was that directed to me?
Yep.
Okay, I apologize. I had you guys on mute. Well, for me, the first encounter, which was being diagnosed. And of course, just as Michele had mentioned, I had never heard of pulmonary fibrosis, nor did my husband, nor did most people that I knew at the time. So on my first encounter of being diagnosed, we knew something was wrong when the doctor was looking at my images of my lungs, and it seemed to me at that time to be about 10 minutes without him saying anything, and constantly looking over. that, I think, was our first indication that there might be something wrong, or something that is not normal. We had no idea the enormity of it. And so my first encounter of being diagnosed as a patient, unfortunately, I was in a daze. I think, I was told after a very long period of silence what it was that I had. I was then proceeded to be told of things that I couldn't do, that I would not be able to do X anymore. You're going to be tired. I was also told during that visit that my life expectancy would be 3 to 5 years. Needless to say, looking back, it probably wasn't the best bedside manner, so to speak. I was in a daze. I don't think that I heard anything probably after the 3 to 5 years of my life expectancy. So for me, as a patient, as a person, as somebody who just gets diagnosed, on that first, obviously anybody who's listening to this, anybody who's involved right now, probably has already been diagnosed. A loved one, a friend, a coworker, somebody in their life. So for me, what's important is that, especially on the clinical side of it, is that the physicians, the doctors, the nurses, the caregivers, everybody who's involved in that team, they actually, they listen to the person and pay attention to the person when they're giving them that need or that news. It is a process, and it's a very lonely process. I think I heard that mentioned. Being diagnosed, it's very lonely. It took me over a year to process the diagnosis, and my husband. And it is a journey. And it's a journey every day. But that initial visit, I think it's so important on the medical side of it and in that environment to actually pay attention. And I like the concept of pictures and visuals, because at one point I got glazed over as a patient. There was too much information being sent to me. It was all negative, and I just glazed over. So the visuals and the pictures, I think those are very useful tools for the patient on that first visit. Keep it simple, yet obviously, if somebody is aware of IPF or pulmonary fibrosis, if it's genetic in their family, by all means, I think it's a good idea to go further. But I really think it's important to key into the patient, to that person, and look at them and just be aware of what it is you're seeing. If somebody's glossed over, they're not going to listen to you any further. They're trying to absorb and keep it positive. Yes, you're welcome.
Thank you so much, Carolyn. So in the essence of time, we're going to move on to the next question so that we can get all of these in here. But the next question is really for Michele, Greg, and David. How do you help your patients and loved ones achieve their best quality of life? And Michele, we'd like to start with you.
Thanks, Chloe. I think for us, it was just becoming educated and informed. I think that was the best thing that we could possibly do for ourselves, and just to know everything that we possibly could, what to expect. I know it's a very unexpected disease, but you have the opportunity to sort of learn from other people maybe. And for us, the support group was really invaluable. And I guess I kind of want to plug support groups, but I get a lot of feedback all the time from the members of my group that they sometimes learn more from coming to the group than they do going to the doctor. It's two different arenas of knowledge. By all means, we are not there to provide medical advice, but what we can do is help people who maybe are early in their diagnosis. I mean, it's invaluable for them to talk to someone who has walked this path and what helped them, what wasn't effective. Maybe this might work for you, but it didn't work for us. The give and take in a support group, I think, is just so essential for someone with pulmonary fibrosis and their caregiver as well.
That's great, Michele. I couldn't agree more. This is Greg. I might expand a bit maybe on the medical side in terms of how I think about quality of life above and beyond the education standpoint. And it gets back to Carolyn's comment. What is important to the patient and their family? Where do they see themselves 2 or 3 years down the road, regardless of what the statistics suggest, whether or not they're relevant? But that helps me understand how to support them through that journey. And the barriers of one patient reminded me of much what Carolyn said is, I can't go skiing anymore. My response was, why not? Well, I am on oxygen. And my response was, you're a world-class downhill skier. Why don't you just bring oxygen with you? Because that's part of who she was as a person, much the same, it sounds like, running and those activities were to Carolyn, and supporting her to help her do the things that she finds enjoyable and important in their life, and understanding what they are, and then working with them to try to continue to achieve them for as long as possible. I think most individuals, when they're affected by any disease, they understand that there is a new normal, like Patti had mentioned. And I look at my goal as a physician, and perhaps how I advocate nationally, is how do we help people continue to be as happy as possible? And I think that feeds into their quality of life as we better understand the science and ask for their volunteerism and to help us do that, because it's so important. But the two aren't exclusive. You can maintain a great quality of life and participate in the community, as Michele said. So I think it really is understanding what your patient's goals are and communicating effectively and realistically. We can't achieve every goal, but we can achieve and meet some of them, and that really is just a discussion that has to be addressed, as frequently as possible, and readdress when things change, whether good changes or sometimes when they're disappointing changes, and maybe some new limitations, increasing breathlessness or increasing need for oxygen. It's just a never-ending target sometimes, and readdressing it is really important.
That was great, Greg. I'll be very brief. I have a kind of standing list of 5 things that I think help improve quality of life in ILD or in PF, and that's adequate supplemental oxygen, pulmonary rehab, support groups, which were already mentioned, education, including the information on the PFF website, all the educational materials PFF has, and the educational webinars. And the 5th one, which is really not available for most people, but can be helpful, is lung transplantation. So those are, in my experience, the only things that really improve people's quality of life with PF, although I'm always willing to learn about other things that help too.
Great. So our next question is, as a patient or caregiver, how do you track and monitor symptoms over time to effectively manage pulmonary fibrosis and stay prepared for clinician visits? And this one's really for Carolyn and Michele.
Well, for me, what I do daily, and I keep a journal, a log, so to speak, and every day I use oximeter, and it is monitoring my SpO2 levels. And I know the range that when I feel good and, I'm not short of breath, I know that range for me, that percentage. So I keep that logged every day. I typically take a reading about 3 times a day and just log it, just like, a little journal, day planner, so to speak. What I also do is I use a spirometer. It's I'm not sure if I'm pronouncing that 100% correctly, but I breathe into it, and I know, I mark where I can get to the highest reading on that, and I mark that down. I write that down. The next day, I do the same thing. I do the breathing exercises and try to get to a higher mark, and I mark that down as well. And I keep that in a logbook. With that, I also keep track of the weather, the temperature. I do better in 40 to 75 degrees, and I do well with humidity under 50%. And so I keep track of those stats as well. And when I do go for my visits, I will take that journal with me. And, if I'm short of breath, I write that down. It's just, think of the old daily day planners. I keep a pen and paper available, and that's what I use.
Great. Michele?
I think that, Carolyn, what you do is fabulous, and it's a great way to track everything. There's currently, though, lots of new apps for iPhones and Androids and devices that patients can, they can track their symptoms on a daily basis very much the way you do. Great strides have come helping patients live a better life with these nice little devices and applications for their phones. We kept a spiral notebook of really most of our visits, writing down the questions as we thought of them, things that concerned us, and I always brought that with to every single doctor's appointment. And I tried to make sure I could get all those questions answered and write the answers down so that it helped us to become better informed. And I actually still have all of this information, but my husband kept all of his CT scan results. He kept all of the breathing, all those breathing tests that he did. He kept those as well. And so that would help to show us where things were headed, how quickly they were headed. But we always had that with us. And we just kept track of everything that we could. One of these days, I probably will get rid of all of that, but I still have it.
All right. The last question before we dive into our question and answer session is for the whole group, but we'll start with Patti. How can organizations like CHEST and the Pulmonary Fibrosis Foundation help to facilitate or improve the communication between patient and provider?
Thanks, Chloe. I've given this a lot of thought, both professionally and personally over the last several years. And I think what really held us together and really just launched us as a foundation at PFF was, it sounds aspirational, but our North Star really was, how do we imagine a world without pulmonary fibrosis? If you are somebody who is being treated or somebody who is part of a treatment team, what's our obligation, and what is our sense of hope and support? How do we commit to somebody or a family who now has to deal with this disease? How do we get creative in a collaborative manner? Dave and Greg and so many others put this care center network together that was and is meant to do that, to connect at so many different levels to support and educate. I know you all today, Chloe and Angela, have over 200 people who are on this webinar. And how important is that? And I hope really that this isn't a one and done situation so that people do feel connected. People also want to be listened to and they want to feel empowered. And I think, I look at you, Michele, and Courtney, and what you've been able to do in honor and memory of Jeffrey. The support groups, the community events to try to keep his memory alive and to help so many that unfortunately now are also dealing with the disease. I think that this is something, whether you are a part of a formal organization, you want to start your own, or you're somebody like me now who lost somebody 10 years ago and who was always worried that the other shoe is going to drop and somebody else in my family is going to have to deal with this. How do we fit? And I think that we as individuals have a responsibility to kind of figure out how does that look in our lives, as well as I think the organizations have a responsibility to feel out and listen to what is the mission, how do we best serve and empower the community. And you know, I think that there are many amazing options, and we're so blessed to have them in the PF community. And I certainly hope that we continue to flourish and support each other until we can find out solutions for not having to deal with this disease, and we can imagine a world without pulmonary fibrosis.
Great. Dr. Cosgrove or Dr. Lederer, would you like to add to that?
Yeah, hi, this is Greg Cosgrove. That's great, Patty. It still really affects me when I hear those words. It really is the aspiration to keep everyone in the community, and not just at the Pulmonary Fibrosis Foundation, but the entire community. We have to work together and collaborate with everyone in the community, patients, caregivers, industry, the NIH. It really, I think that's how we've been able to make major advances in understanding the disease. But in regard to this specific question, the thing that I've learned over the past several years, and maybe this is putting the CMO hat on for the PFF, is listening to the community and understanding and asking the questions that don't get asked in the physician's room, or what are the issues that we wished were addressed in the physician's room, and then help those that are caring for patients understand maybe the unmet needs, the unmet understanding about the disease. A perfect example are some of the surveys we've done where it's quite clear that patients want to know more about clinical trials and where they are, and perhaps have an incredible interest in participating, but the deficit in that was the physician that was caring for them never even asked them about it, even though the patients were interested. And that was an insight to maybe develop the clinical trials finder that we just launched, so patients can take the responsibility and use that interest to better understand what things they could participate, or what education resources are out there. So it's an important understanding to see maybe some of the limitations of the time physicians have, but not use that as a barrier and work outside the exam room, and communicate in maybe in non-official ways with the resources, the education resources from the different societies and the foundation. But I think Michele really emphasized one of the major important resources, which are the support groups, because that's a new level of information that is communicated, and supporting them to give them a venue, or just maybe some ideas how to form the support groups and use the knowledge that Michele and you have to foster and support people that have an interest but have never done it before. That's really basic ways in which we can make a big difference in the community that really spreads from one person to another, whether they're patient or caregiver. So it is an important aspect. And maybe just to expand on Michele's comment, and then I'll let Dave comment, is there are great resources and there are apps, and we just launched one, the PF Health app, which will be able to track outside of a journal if you want to use your smartphone. And then there's also a resource with Monarch where they will facilitate and help to scan in all someone's records so that they're readily available for them. So I think we want to use technology appropriately to help patients and not overwhelm them. And that's hopefully what these resources are, where it makes it easier for patients and they can carry it in their back pocket and have it on vacation, so that they can communicate complex information very quickly and have all the records available, which is what patients have asked for in the past. Let's make it easy for them. And I think that's our goal as organizations, to try to make it easier for patients to live as normal a life as possible with a disease that can be overwhelming.
Dr. Lederer, did you want to add to that?
Actually, I don't think I need to. Greg, you said everything really, really well, and I agree with everything.
Perfect. Michele or Carolyn, did you have anything that you wanted to add that was potentially maybe something that would be helpful for you to have, or something that you think that we could provide for you, whether it's an organization like CHEST or Pulmonary Fibrosis Foundation?
Well, I think that, oh, go ahead, Carolyn.
No, please go right ahead, Michele.
Well, thank you for all the shout outs about the support groups. That is a key tool. But information like this webinar, it's really, really important to the PF community. Local educational events, printed materials, user-friendly websites, those are all invaluable tools to help the patient. And quite frankly, focus on the patient is the key. They are desperate for information. And the more that can be easily accessed by them, it'll make them better educated patients who can actively participate in their own future of this disease.
Michele, I couldn't have said it any better. You were exactly right, and exactly what I was thinking and what I wanted to say about we are desperate for information. And a lot of times what we find, it's very scary information and very devastating. And we're looking for information that's more positive, something that's going to give us hope. And keep the technology simple. Clearly there's a lot of people, all age ranges, that, have been diagnosed with pulmonary fibrosis. Not everybody is computer savvy, technology savvy. So keeping the platforms that you're putting the information out, the different, computer compared to the apps, Windows platform and an app platform. I think that makes it more accessible to more people, and keeping that information simple. Also, the last thing I'd like to say is encourage and listen to the person to have them live their life to the fullest. Every single one of us are at different stages. And it's nice when there is somebody who can understand the stage and support that stage that we're at. All we want to do is live a full, productive, positive, and a very joyful life. Building that personal relationship with us, get to know us, and not just the disease. So thank you.
Thank you, Michele and Carolyn. So I do have a couple of questions before we end today's webinar, and so I'll get started with the first one. And if you do have any questions, if we have time for them, we will definitely try to get to them. Please type your questions in the control panel for GoToWebinar. So my first question is, where can patients go to find comprehensive information about staying on IPF medications? And that's kind of open to the panel.
Well, this is Greg Cosgrove. I think first and foremost, when you're talking about medical therapy with the antifibrotic treatments, it's really important to discuss those issues with your physician because that's a prescribed medication. So I think those questions certainly are important, and that gets back to the relationship. If you're having any changes, positive or negative, there has to be an open dialogue about that. And I'd emphasize that with all the constraints sometimes. But also there are a lot of other resources with web-based information that describes the efficacy of the different medications, as well as potential side effects, and again, underscoring why you really have to have that frequent interaction with your physician when you're on any medication, so that side effects, if present, can be addressed up front. If not present, fabulous. And then also understand and serially monitor patients, because any therapy could have potential side effects. So as the physician, it's important for me to recognize that, but then also as an advocate, I think that there are so many different resources, and as Patti would say, we really want to make sure the best information gets to patients so that it's trusted and validated, especially in the day and age. The internet is a great resource, but sometimes information can not be as trusted and checked on a regular basis. So making sure that that exists, whether it's the CHEF's Foundation, the PFF website, or other resources like WebMD, or the Mayo Clinic has a great resource. So a lot of these are really important moving forward, so that patients get the most accurate and best information, and can work with their clinician to modify any potential therapy.
Thank you. And then the next question, which is probably a little bit similar in the answer that we're able to give, but I wanted to ask, it's where can I go to get questions answered that sometimes our clinician doesn't have the time to answer? Is there a way to find these answers from informed clinicians, even those who aren't fully aware of the patient file?
Well, this is Dave. I can try to address that. It is a tough thing, and I know exactly what the question asker is getting at, because there is it can be hard to get complete, accurate information during a patient encounter, that is during a visit with your doctor. There is accurate information out there in general about pulmonary fibrosis. I've alluded to it before. There's a lot of very good patient-friendly information on the Pulmonary Fibrosis Foundation website, which is pulmonaryfibrosis.org. Getting to specific, detailed questions about an individual person's situation, there is honestly no way to get that type of information unless you're seeing a healthcare provider in the office during a medical encounter. And the reason for that is that none of us physicians are really able or permitted to give medical advice or make medical recommendations to individuals who are not our patients. And this comes up a lot. Patients reach out to me or my colleagues who aren't our patients, but they're people living with pulmonary fibrosis, and my hands are kind of tied in that circumstance. So one solution is, if you are living in an area that's within travel distance to a Pulmonary Fibrosis Foundation care center, then getting an opinion from the team there is probably worthwhile. And you can search for Pulmonary Fibrosis Foundation care centers on the Pulmonary Fibrosis Foundation website, which again is pulmonaryfibrosis.org.
Great, thanks. And then one final question. How can each group be complementary to one another to create the best patient engagement, whether we're talking about patients, doctors, industry, advocates? What are some final thoughts on that?
Well, I guess this is Dave again. I mean, just briefly, one of the ways that this is happening is through the Pulmonary Fibrosis Foundation Summit, which happens every other year. The last summit was just a couple months ago in November 2017 in Nashville. Now it's only every other year, but at that are patients, caregivers, physicians, nurses, other healthcare providers, scientists, researchers, people from the National Institutes of Health, and folks from industry, whether it's pharmaceutical industry or other related companies that have an interest in pulmonary fibrosis. So I would say that's the one great way that different stakeholders kind of get together.
And Chloe, this is Greg. I might expand a little bit on Dave's comment that I think the resources, there are certainly national resources, as David mentioned, but there's also the community regional resources, and empowering the physicians that maybe aren't at a care center site and don't have, frankly, the luxury of some of the resources that the sites have. But it's incumbent upon those sites, and I look at CHEST and the PF Foundation and all the other stakeholders as to be inclusive and make sure that we bring in as many partners in the fight against this set of diseases, so that it really is an inclusive community all working together. And the common goal is, as Carolyn and Michele and Patti mentioned, is really focused on the patient to make sure that their lives are enhanced, and we move the ball forward in caring for them.
Great. Thank you all so much. This is the end of the webinar, and just want to thank all of our panelists and all of our attendees. On this last slide, you'll see a few of our upcoming webinars. We've got Women in Pulmonary, Being an Advocate for Yourself on March 21st from 3 to 4 p.m. Central Time. And then we also have another Women in Pulmonary webinar coming up that discusses gender differences in diagnosing and treating asthma, COPD, and ILD. Coming up in April on the 23rd from 2 to 3 Central. There is more resources available not only on pulmonaryfibrosis.org, but also on chestfoundation.org/pulmonaryfibrosis. And there will be new materials coming that way within the next month as well. So thank you again. And if you have the time, there will be a little survey at the very end. And we would love it if you would take a second to fill out that, I believe it's a 5-question survey. So thank you, and thank you to all of our panelists again.
Thank you so much, Chloe and everyone.
Yeah, thank you.
Thank you.